This is the first part of the video lectures on Chapter 20, the heart. This is going to be in pieces. It's really long, and I'm hoping you're going to relate what you learned in lab on heart anatomy, particularly with this first part. There are 4 learning outcomes for this chapter. The first one is on the anatomy of the heart. The second one is on the physiology of heart muscle tissue. The third is at the organ level, the cardiac cycle, and the fourth is on regulating the heart. Be sure to refer to your textbook as you're listening to this lecture. The cardiovascular system includes not just the heart, but the blood and the blood vessels as well. A little broader category is the circulatory system, which would include the lymphatics, but we'll study them separately. We say the heart has 2 circuits. There are 2 sides to the heart. So one side, the right side, pumps blood to the lungs where it picks up oxygen and then pumps that, and then that blood is carried back to the left side of the heart. The systemic circuit leaves from the left side, goes out to all of the systems of the body, and then comes back to the right side. Both sides are intertwined, so you have the same amount of blood going out of both sides of the heart with each heartbeat. You send as much blood to your lungs with each beat of the heart as you send out to your entire body. Here you can see a diagram showing you the pulmonary circuit. Each circuit includes arteries, capillaries, and veins. You need to remember that arteries are the vessels that carry blood away from the heart, and veins are the vessels that carry blood back to the heart. You'll learn about the different kinds of the arteries and veins in the next chapter. So again, arteries and veins, and then capillaries are microscopically small, and that's where the actual nutrient and waste exchange occurs, is in the capillaries. So the whole job of the heart is to push the blood through to the capillaries where nutrient and waste exchange can occur. The heart has 4 chambers, 2 upper chambers and 2 lower chambers. 2 chambers on the right. The right upper chamber is the atrium, right atrium, and that sends blood to the right ventricle. On the left side, the left atrium sends blood to the left ventricle. The right atrium is receiving the blood from the systemic circuit, so it's already had some of the oxygen removed. We call it deoxygenated blood. It's going to go out to the lungs to pick up more oxygen. So the right ventricle pumps the blood to the pulmonary circuit out to the lungs, and then the blood returns from the pulmonary circuit full of oxygen to the left atrium, where it goes to the left ventricle to get pumped out to the body systems. The anatomy of the heart is pretty basic. The base is actually at the top side, the way the heart lies in the body. The apex is just sort of the little pointed tip, and it is inferior and points to the left. So the heart actually rests in your thoracic cavity on the diaphragm, more or less on its right side. The mediastinum is that area between the 2 lungs. That's a term you need to be aware of. So here you can see, in this anterior view, you can see the heart kind of nestled between the 2 lungs. You see the apex of the heart pointing towards the left lung, and all the great vessels of the heart come off the base. That is, they all project superiorly. The fibrous sac around the heart is called the pericardial sac. The outer layer of the pericardial sac is the fibrous pericardium, and it's lined by an inner serous pericardium. Now, I know you learned in A&P1 the serous membranes. So you have pericardium, pleura, and peritoneum. And you remember that each serous membrane has 2 layers, a parietal layer and a visceral layer. I'm sure you also remember that the visceral layer is actually on the surface of each organ. So in terms of the pericardium, the pericardial sac, only the parietal layer of the serous pericardium is part of the parietal sac. The visceral layer, also called the epicardium, is actually part of the heart itself. It's the outer layer of the heart. The pericardial cavity is simply that space between the parietal and visceral layers. I know you remember serous fluid from last semester. Serous fluid is the fluid between parietal and visceral layers of serous membranes. And so since this is surrounding the heart, it's called the pericardial fluid. So here is a cross-sectional view, and you can see the black outlines of the pleural and pericardial cavities. Find where the pericardium is labeled. So you see on the bottom right side, the visceral pericardium is labeled, the pericardial cavity. What your book calls the pericardium, I think it's better called the pericardial sac, so that we're not getting all our pericardiums confused. Here you can see how the pericardial sac develops. On the right, look at our analogy, a fist getting punched into a balloon without breaking the balloon. So this is a review of what you did last semester when you first studied serous membranes. So review that and make sure you know that the fibrous pericardium is the outer layer of the pericardial sac. The inner layer of the pericardial sac is the parietal layer of the serous pericardium. And deep to that, of course, is the pericardial cavity. And then inside of that is the heart. And the outermost layer of the heart is the epicardium, which is also called the visceral pericardium. Okay, this is all important because sometimes these membranes can get inflamed. Pericarditis is an inflammation of the pericardium, typically caused by a virus or bacterial infection. And what happens is that inflammation causes the surfaces to rub against each other with every beat of the heart. This is extremely painful. And it can also cause the accumulation of fluid in the pericardial cavity. And as that fluid accumulates, it kind of squashes the heart. The pericardial sac is fibrous and it can't expand. It's not like elastic tissue in your lungs. And so if too much fluid accumulates, then it literally stops the heart. So that's what cardiac tamponade is. It's just a stopping of the heart due to the accumulation of fluid in the pericardial cavity. That could be from pericarditis, but it can also be blood that's accumulating in there. And it requires, heroic emergency procedures of cutting open the chest or cutting open at least the pericardial sac to let that fluid escape. Okay, moving on to the anatomy of the heart itself. The upper chambers, the atria, are very thin-walled. Each of them has on its anterior surface an auricle. Auricle is an ear-shaped flap, and these are on the anterior surface, so that helps you identify the front of the heart from the back. The atria are separated from the ventricles by a pretty deep groove. You'll remember from studying the brain that a sulcus is a groove. So sulci is just the plural of sulcus. And so everywhere there's a separation between any two chambers, there's going to be a sulcus. The coronary sulcus is the boundary between the atria and the ventricles. But between the two ventricles, right and left, there's also a sulcus, one on the front and one on the back, the anterior interventricular sulcus and the posterior interventricular sulcus. Now, if you're looking at an actual real heart, there's so much fat in just sort of accumulating in these sulci that makes them kind of hard to see. So you're probably going to see the fat in the blood vessels more than you're actually going to see the little groove. In relation to the rib cage, this is important when you're dealing with live patients and you're trying to find the apex of the heart or the base of the heart. So you need to have some concept of where the heart lies. And so you'll notice the apex of the heart is kind of in between ribs 4 and 5 on the left, whereas the base of the heart sits about at rib pair 3. This is an important figure for you to study, probably more for lab than lecture. I'm probably not going to ask you a lot of heart anatomy in lecture because I know you're studying it in lab, but you can see the auricle of the right atrium. You can see the right ventricle takes up a lot of the real estate on the front of the heart. The left ventricle makes up the apex of the heart and continues more on the back side of the heart. So just the way the heart sits in the body, the right is more towards the front and the left is more towards the back. Please notice the blood vessels. Starting on the left, we have the superior vena cava. This is the major vein that drains blood from the head, the neck, and the arms. And it enters the right atrium. That's from the system. We'll see its partner, the inferior vena cava, on the back side. You'll also see the aorta. This is the major vessel that supplies blood out to the systems of the body. And it has several regions visible here. The ascending aorta, the arch of the aorta, and the descending aorta are all visible in this picture. The arch of the aorta is the highest part of the aorta. It has three major vessels that come off of it. The one that goes to the right side is called the brachiocephalic trunk. Pay attention to the word roots. Brachio means arm, cephalic means head. The left common carotid artery is going to go up the left side of the neck. The left subclavian artery is going to go out to the left arm. There's a small vestigial structure called the ligamentum arteriosum. We'll study that more when we look at the embryology of development of the fetal heart. And then you can see the pulmonary trunk and the left pulmonary artery. Don't you know there's also a right pulmonary artery? It's just behind the ascending aorta. So study this diagram. Make sure you're comfortable and familiar with it. And also with, we're not going to worry about it on the real specimen. You can look at that if you wish. But also on the back of the heart, the posterior surface, again, the left ventricle takes up most of the back of the heart. The right ventricle is much smaller. Look at all that fat and those blood vessels in the sulci. And we'll come back and identify those blood vessels later. Here now, on the back of the right atrium, you can see the inferior vena cava. On the back of the left atrium, you can see two on the left, two on the right, pulmonary veins. These are the veins that are draining blood from the left lung and the right lung. And above them, you can see both the left and the right pulmonary arteries. We'll look at those vessels again when we study the respiratory system. Now, as we get into the layers of the heart wall, you'll remember that the epicardium is the visceral pericardium, and that's the outermost layer of the heart itself, and it lines or it covers the heart to reduce friction between the heart and the pericardial sac, and it does help secrete that serous fluid, pericardial fluid. The business tissue of the heart, of course, is the cardiac muscle tissue, and that's in the thickest layer. It's called the myocardium. You'll remember myo means muscle. And then the innermost layer is called the endocardium. And like the epicardium, it's a simple squamous epithelium. It's just sort of a lining. It reduces friction. It makes the blood less likely to clot when it's sitting in the heart. And it just keeps a nice slick surface on the inner surface of the heart. So in this diagram, you can see those layers, the endocardium, the myocardium, and the epicardium. Please also notice there's some connective tissue in the myocardium along with the cardiac muscle cells. That connective tissue helps hold the cells together. It binds it all into one big organ and keeps your heart all connected. As you look at the way the cardiac muscle tissue is arranged, the muscle fibers, the muscle cells form little tracts, and you can see kind of the layout of those tracts here. So you see that the musculature sort of spirals around the heart. This helps kind of squeeze the blood out of the heart. Although I have to say that generally speaking, when you're at rest, you're not squeezing all the blood out of the heart. So back to that connective tissue. It's a fibrous connective tissue. It helps to connect the cells to each other and to the supporting tissues like the blood vessels. It does help the heart, help keep the heart from overexpanding. There is some elasticity in it, not a whole heck of a lot, but it does let the heart, kind of return to its original size after it stretches. And the only place that connective tissue actually kind of coalesces into a real structure of itself is in what we call the cardiac skeleton. And these are tough bands of elastic tissue that circle the valves, stabilize the valves, and insulate the ventricular cells. Let's take a look at a picture of that in just a minute, and we'll be able to see that. So in separating the chambers of the heart, we have the septa. Remember, septum is just a wall. So interatrial means between the atria. Interventricular means between the ventricles. So it separates the left side of each chamber from the right side. And back to the connective tissue, that layer of connective tissue that separates the atria from the ventricles includes the valves. We have 4 valves. One between each atrium and each ventricle is called an atrioventricular valve, and one between each ventricle and the artery that it supplies. And so these are named more or less properly by where they are, but we have some other names for them. So, for example, the right atrioventricular valve is also called the tricuspid valve, and the left atrioventricular valve is also called the bicuspid or mitral valve. Now, I hate to saddle you with all these names, but people do use them all. So you'll hear of, say, mitral valve prolapse. The mitral valve is a really important big valve separating the left atrium from the left ventricle, so you have to learn all the names. The purpose of the valves is to prevent backflow. That is, to keep the blood flowing only from atrium to ventricle or only from ventricle to artery. If the blood tries to go backwards, the valves will simply shut. And the way they work is different for AV valves than it is for semilunars, and in a minute we'll look at a picture of that. The semilunar valves are the valves between the ventricles and their outflow. On the right, that's the pulmonary valve, and on the left, that's the aortic valve. All right, here are the vessels for the chambers. We're going to get started on those. The right atrium receives blood from the superior vena cava. Again, that drains the head, the neck, and the upper limbs, and also the upper chest. And then the inferior vena cava is carrying blood from below the diaphragm. So that's from the torso, from the viscera, and from the lower limbs. Features of the right atrium: there's a depression called the foramen ovale. This is a vestige of a fetal structure. There was an opening between the two atria in a fetus because they're not breathing using their own lungs. They're getting oxygenated blood through the placenta. And the foramen ovale is actually the opening, and then at birth there's a little valve over it, it seals shut, and that little thin spot is called the fossa ovalis. Another feature of the right atrium is muscular ridges in the auricle. These are called pectinate muscles. You'll see them in the left atrium as well. If you see pectinate muscles, you've got to be in an atrium. If you're in an atrium and you see ridges of muscles, they have to be pectinate muscles. Okay, so leaving the right atrium and going to the right ventricle, we're going to go through the tricuspid valve. It's called that because it has three flaps or cusps, and the lower edges of the valves attach to these strings, these cords within the ventricle. They're actually considered to be your heartstrings. These are the chordae tendineae, and the other end of the cords attach to lumps of muscle in the ventricle called the papillary muscles. When the papillary muscles contract, as the ventricle contracts, it pulls on the cords, and that keeps that valve from opening backwards. So here we're looking at this diagram showing us the flow blood. Follow the blue arrows from the superior vena cava at the top on the right side, from the inferior vena cava at the bottom on the right side, and of course that's the anatomical right, into the right atrium. You can see the fossa ovalis. You can also see the flow of blood through the tricuspid valve. You can see the strings, the chordae tendineae, that attach it to the papillary muscle. We're going to do similarly for the left side, so you might want to refer back to this picture as we go through those. Some other features of the right ventricle: there are ridges of muscle in the ventricles as well. These ridges are called trabeculae carnii. Now the names get a little tough. You're just going to have to learn how to spell them. Notice that it's always A-E at the end, so A before E. And don't get the ridged muscle confused. There's ridge muscle in the auricles, that's the pectinate muscle. If it's ridge muscles in the ventricles, it's trabeculae carnii. There's also a structure found in the right that's not found in the left. It's called a moderator band. I hope you get to see one on an actual specimen in lab. This connects the outer wall of the right ventricle to the inner wall of the right ventricle, and it's thought to help reduce the likelihood of overexpansion, but it does carry specialized cells to conduct excitation into the papillary muscles as well. All right, so here you see just a nice photograph of those chordae tendineae and papillary muscles. Again, the papillary muscles are down in the ventricle. When they contract, they pull on the chordae. They don't close the valve. They don't open the valve. They just keep the valve from opening backwards. And here we just see a nice specimen. I hope you get to see one in lab. Notice how much thinner the wall of the right ventricle is from the wall of the left ventricle. Notice also that the apex of the heart is made up just of the left ventricle. The right ventricle doesn't go all the way down to the apex. And then pay attention to the valves as well. The AV valves have strings attached. That's the chordae tendineae. The semilunar valves do not have any strings attached. They look like little cups. All right, at the superior end of the right ventricle sits a structure called the conus arteriosus. I am not going to test you on this. I think it's important, but I think it's just too much detail. The conus arteriosus is simply that the part where the pulmonary trunk attaches to the right ventricle, it contains the semilunar valve, and it leads into the pulmonary trunk. So as far as I'm concerned, the right ventricle attaches to the pulmonary trunk, which is only about an inch long and then divides almost immediately into left and right pulmonary arteries. And when you see the term trunk in reference to an artery, it's always going to be short and split into two pretty equal pieces. All right, so moving on to the left side of the heart, we're receiving blood from the left and right pulmonary veins. Remember, it's high in oxygen. We're going to go through the mitral valve. That's the left AV valve. Again, refer back to the diagram. And it's also called the bicuspid valve because it only has two little flaps on it. As you get into the left ventricle, there's no moderator band. There is, again, a thicker wall. The papillary muscles are much beefier, and blood's going to move from the left ventricle through the aortic semilunar valve into the ascending aorta. Aortic sinuses are important, but we're just going to look at them later when we look at regulation, and you don't need to remember those. The ascending aorta is only about an inch long, and then it starts to curve at its high point, and that's the aortic arch. And after it makes this hairpin turn and the blood starts flowing down towards the feet, that becomes the descending aorta. So again, looking at the left side here, you can see the little red arrows sending blood from the lungs to the left pulmonary veins on the far right of the diagram, into the left atrium through the bicuspid valve or mitral valve, down into the left ventricle, back up through the aortic arch to the ascending aorta through the aortic semilunar valve to the ascending aorta, the aortic arch, and then to the descending aorta, which you can see at the very bottom of the picture. All right, so I told you earlier that because the blood goes from the pulmonary circuit directly to systemic and back again, the two sides of the heart will pump pretty much the same amount of blood, but they pump it at different pressures. So the right side is only having to pump out to the lungs. That's kind of sideways, and it's not very far away. So that doesn't take a lot of pressure, and so the right side has much thinner walls than the left side. So looking at this diagram, here we have a cross-sectional view through the ventricles, and you can see just how much thicker the left ventricle is than the right ventricle, and you can see the differences in the shape, but remember the volume is pretty much the same. They can both hold about the same amount of blood. Okay, so here you can see the differences when they're dilated, that means they're full of blood, and when they're contracted, that means when they've squeezed most of the blood out. All right, back to our valves. We're going to focus on what their function is. Remember that the function of the valves is to prevent backflow. The AV valves are between the atria and the ventricles. You have a tricuspid on the right, a bicuspid on the left, and what closes the valves is simply when the blood tries to flow backwards. So the valves are prevented from opening backwards by their structure, and in the case of the AV valves, it's the contraction of the papillary muscles pulling on the chordae tendineae that prevents those flaps from just blowing open in the opposite direction. For the semilunar valves, they don't have heartstrings, chordae tendineae, but what they do have is a sort of a cup-like structure. So when the blood tries to flow backwards from the pulmonary trunk or the aorta back to the ventricle, these little cups fill up and they block the opening. And yes, you can have valvular disease from any one of the valves. It can be from inflammation, that would be carditis. Sometimes children get rheumatic fever. This is a complication of a strep infection, so if you have strep throat, then that can go on to rheumatic fever. And very often the valves can deteriorate to the point where you have to have an artificial valve put in. So in this diagram, this is showing in the upper larger picture, you're looking at those 4 valves, the larger AV valves and the smaller aortic and pulmonary semilunar valves. But look at the photograph at the bottom left, and that helps you appreciate just how the semilunar valves are going to operate. So now we're looking at a coronal section, a frontal section of just the left side, and you can see how the valves sit right next to each other, but how the flow of blood is controlled. So notice in this diagram, the AV valve is open because blood is flowing from left atrium to left ventricle. Blood is not supposed to flow right now from the semilunar valve, so notice that it's closed. So as the ventricles contract, that pushes open those aortic and pulmonary semilunar valves, and blood can flow from the ventricles to the arteries. All right, so here you see that in the frontal view, and you can see that now that the ventricle is contracting, it pushes up on the blood. As blood pushes up against the mitral valve, it pushes it closed, but at the same moment, it's pushing the aortic valve open. Okay, we're going to turn our attention to the fact that the heart is an organ, and like all organs, it needs its own blood supply. The blood supply to the heart itself is called the coronary circulation. The coronary circulation starts with the coronary arteries. There are 2 major coronary arteries that arise from the aorta, right inside of the aortic semilunar valves. That's that little space called the aortic sinuses. And these are the right and left coronary arteries. And what happens is that as the heart starts to contract, the aorta is going to open. And even when the aortic semilunar valve is closed, there's blood pushing on those semilunar valve cusps, and that allows the blood to continue to flow into the coronary arteries. So the right coronary artery obviously supplies blood to the right side. The right atrium, and then the right side can include portions of both ventricles and part of the conducting system, which is just heart tissue. We'll talk about that later. There are marginal arteries. These are arteries that run down the side or margin of the right side of the heart, and also a very large posterior interventricular artery, which are branches of the right coronary artery. The left coronary artery supplies mostly the left side of the heart. It has 2 major branches. The circumflex artery runs through the coronary sulcus, that's around that boundary between the left atrium and the left ventricle. It gives off a lot of arteries, but the main one that we're asking you to learn is the anterior interventricular artery. These arteries can kind of merge, and we'll worry about this term later, but an anastomosis is a connection between arteries without a capillary in between them, and they just kind of help supply the whole heart, so that if there were a blockage in one artery, well, then another artery can kind of step up and supply that tissue. Now, the heart is drained by the cardiac veins, and there's a number of these. The biggest one is called the great cardiac vein. It starts at the apex. It runs up the anterior interventricular sulcus. It runs around the coronary sulcus, and it dumps into the major venous drainage on the back of the heart, which is called the coronary sinus. And then the coronary sinus is going to dump all that blood right into the right atrium. So the great cardiac vein drains blood mostly from the left side of the heart. And then there's a middle cardiac vein and a small cardiac vein that empty into the right side, or carry blood from the right side of the heart. And then there's various others, and we're just not worried too much about all of those. The main one I want you to know is the coronary sinus, but it's on the back. So take a look at what you can see in this diagram of an anterior view. And remember that in the systemic circulation, red is going to be arteries because red means oxygenated blood. Blue means the oxygen's been depleted. So you should be able to tell arteries from veins, and you should study this diagram and make sure you can identify the left and right coronary arteries, the circumflex artery, the anterior interventricular artery, and from the right coronary artery, the marginal artery, and then we'll see more on the back. Notice the great cardiac vein parallels the anterior interventricular artery. And on the posterior surface, please note the position of the coronary sinus. The great cardiac vein just kind of merges into the coronary sinus, but the coronary sinus has a wider diameter. This sinus doesn't have much tissue in it. It's got lining the same as the lining of all the blood vessels. It's called the endothelium, but there's really no muscle in the wall of the coronary sinus as there is in the wall of most arteries and veins. You can also see the middle cardiac vein paralleling the posterior interventricular artery here. You can see one of the marginal arteries paralleling or dumping into the marginal artery coming off the right coronary artery, the right coronary artery paralleling the small cardiac vein. All right, I am not going to test you too much on diseases of the heart. It doesn't hurt you to know a little bit about them, but just refer to what's on your review sheet for what you have to know for the test. So coronary artery disease is going to be a blockage of the coronary circulation. If you have a blockage of, say, a marginal artery, that's going to be fairly minor compared to, say, damage to the anterior interventricular artery. The bigger the artery, the more problems are going to ensue if that artery is blocked. Cardiac muscle is, like the brain, very dependent on a constant oxygen supply, and consequently, if anything blocks the flow of blood to the heart, it's going to result in the death of cardiac muscle cells, and that's going to be either coronary ischemia. Ischemia just means that there's a partial blockage, or if it's a complete blockage, it's temporary. And ischemia just means reduced blood flow. If it's completely cut off, then the cells are going to die and you're going to have a heart attack. All right, so this diagram just shows you how we're able to image those ischematous tissues. Coronary artery disease is usually caused by plaque formation. Plaques can form from too much cholesterol. It really is a disease process. There's evidence now that a viral infection is going to attack the lining of the vessel wall and cause the development of that plaque. But if you eat too much fat, you do tend to have high blood cholesterol and you're more likely to form plaques. There's also a genetic component to it. Those plaques then can form a rough surface on which a clot, a thrombus, can form. So the plaque itself blocks part of the vessel, and then the thrombus blocks it even worse. And if you irritate the vessel, it can actually spasm. And these spasms in the vessel can cause ischemia because they can contract in a spasm, and then they can relax and blood flow can be reestablished. All right, so here you see a diagram showing you the problem associated with an atherosclerotic plaque. Another common condition of the heart is called angina or angina pectoris. It basically means chest pain. And if someone is having an angina attack, then that's probably a sign of coronary artery disease, but it may be temporary. And some of the treatments for this are drugs that are going to cause the blood vessels to open back up, like nitroglycerin tablets will do that. MI, or myocardial infarction, is a heart attack, and this happens when the blockage is so great that the cardiac muscle cells die. And what happens now is you have an area of dead tissue, an infarct, and infarcted tissue interrupts the normal electrical signaling of the heart when the heart's beating. So if you have a really serious MI, you may have an infarct that prevents the heart from beating normally, and that then can lead to cardiac arrest, complete stopping of the heart. Coronary thrombosis is a clot that forms within a diseased coronary artery. it can cause a stoppage of circulation, which can lead to the myocardial infarction, the MI. So coronary thrombosis can cause an MI, and an MI can cause cardiac arrest. Okay, so here you see that if you have damage in one of the major coronary arteries, wherever that damage is, that's going to determine how much of the heart is affected. Okay, so again, with myocardial infarction, it depends on how big the artery was, how much of the area is damaged, exactly where the damage is. If it's just a small area, you may survive, but if it's a particular area that's involved in transmitting the signal to the rest of the heart, you may have complications such as cardiac arrhythmias. And the chest pain that goes with an MI is vague, and it's hard to pin down. And actually, men often are more likely to experience chest pain than women are. Women sometimes describe they just feel like there's a sense of pressure on their chest more than pain. And sometimes the pain is associated with something else. If your esophagus is inflamed, it feels just like a heart attack. So you have to go, you have to get it diagnosed. They're going to do electrocardiography. They're going to look at blood enzymes to see if you have damaged heart cells. You do not need to know what those enzymes are. You just need to recognize that we can tell if someone has a heart attack by doing blood tests. So for treatment, well, assuming you survive, you're going to be looking at reducing the odds of another MI, reducing the likelihood of another coronary thrombosis by going on anticoagulant drugs that prevent clots from happening. You might need a pacemaker to help make sure your heart rhythm is strong and that you don't have blood stagnating in the atria. And that's all very complicated. So we're not going to get bogged down in that. Obviously, you can reduce your risk of a heart attack by not smoking, treating high blood pressure, eating right, reducing your stress. Very hard for A&P students to do. You have my sympathy. But you could increase your physical activity. Try to go for at least a 30-minute walk, even if it's just across campus or up and down the stairs or outside. Try to get some exercise in every day. I'm not at all going to worry about the drugs. Some of them, though, are things that we'll relate to later. So you want to know that aspirin is an anticoagulant. Coumadin is very often prescribed as an anticoagulant. Other drugs are going to block the sympathetic nervous system. I already mentioned nitroglycerin is a drug that dilates the blood vessels. And then you have calcium channel blockers. We'll come back and talk about them later. And pain relievers and other clot-busting drugs. And I'm not even really going to worry too much about the surgery. I think if you're interested in that, you can read about it. You may have family members who've had an angioplasty. Angio just refers to basically arteries. So anything you're doing to arteries, if you're imaging them, you're doing an angiogram. Here we're doing angioplasty to try to get plaque squashed against the side. The success rate is variable, and I'm hoping they're going to come up with a better way than angioplasty to have long-term treatment of atherosclerosis. Grafts and so forth are just another way. So you may have met someone who's had a single or a double or a triple or even a quadruple coronary bypass. They're just talking about how many arteries they had to go around. Okay, we're going to stop here, and I will start with the conducting system in part 2, so stay tuned.